للمؤتمر. كل الشكر والتقدير لاستاذنا استاذ دكتور اسامه على يعني ما شاء الله المجهود الرائع وعلى المؤتمر الناجح، وبالتوفيق دايما ان شاء الله. اول سيشن معانا هيبقى للقامه العلميه الكبيره في مصر والعالم العربي وفي اوروبا، استاذه دكتوره رشا طريف، أستاذ ورئيس اسم الأطفال والسكر والغدد الصماء في جامعة عين شمس، اللي هتمتعنا كالعادة واللي بننتظر محاضرتها كل عام بصراحة. يعني ربنا يبارك في حضرتك وبنستنى حضرتك دايما يا فندم.
ربنا يخليكي. مساء الخير على حضراتكم. يعني بشكر حضرتك على التقديم الجميل. بشكر الأخ العزيز الأستاذ الدكتور أسامة حسين على دعوتي، من أحب المؤتمرات لقلبي، وأصلا إن أنا أجي بورسعيد واتفر السبب إيه ده شيء بيسعدني جدا، وعايز أجي كل يوم، عايز أجي على طول. يعني هنروح للإندوكراين شوية، هتكلم على توبيك أعتقد إن هو كومن شوية. كلنا كبيدياتريشنز بنشوف ثايرويد فانكشنز وبنبقى محتارين إمتى نعالج وإمتى نستنى شوية. فهاخد حضراتكم كده لرحله في البيدياتريك سب كلينيكال هايبوثايرويدزم، والسؤال الصعب قوي هحاول اجاوب عليه: to treat or not to treat. We have a lot of variable thyroid disorders. I'm going to focus on this box, the box of having normal T4 with a high TSH, which is a conflicting part. And this is the updated definition of subclinical hypothyroidism when we have high TSH with normal T4. And remember, this is a biochemical diagnosis because 80% of children and adolescents are asymptomatic, and this is what makes it a bit more difficult. When facing a child with subclinical hypothyroidism, these are the frequently asked questions. Is it transient and will resolve? Could it progress to overt hypothyroidism? To treat or not to treat? And if we decide to treat, is it a lifelong treatment or not? هي دي الأسئلة اللي عادة البيرنتس بيسألوها للدكتور. And looking at the clinical course of subclinical hypo, again the question: is it transient or for life? Luckily speaking, 50% continue as subclinical hypo, 40% revert back to euthyroidism, which is a very good percent, and only 10% develop overt hypothyroidism. And this is a paper that showed the risk factors of thyroid dysfunction, and the risk of progression in pediatrics is generally low. عكس الادults. معظم الادults they progress to overt hypothyroidism. In children, it is not very common to progress to hypothyroidism. And the main risk factors are the baseline TSH. The higher the TSH, the more the risk, and the BMI Z score. The more the BMI, the more the risk of progression. And you can see here that idiopathic subclinical hypothyroidism is self-limiting, but the risk of progression is more with Hashimoto thyroiditis, and if we have other autoimmune disorders or chromosomal aberrations. In the box on the right side, you can see that Hashimoto thyroiditis is the most common cause, 60 to 80%, and the least is idiopathic. And please remember to ask the patient if he or she is on drug treatment, because you can see a list of medications which could lead to subclinical hypothyroidism, especially anti-epileptic drugs. And here you can see that subclinical hypothyroidism lies under the category of mild hypothyroidism. And we have two categories: either mild when the TSH is less than 10, or severe subclinical hypo when the TSH is above 10. So the difficult question that we face to treat or not to treat subclinical hypothyroidism, which way shall we go? جمعت لحضراتكم شوية references بس الحقيقة الخلاصة there is no clear consensus when to treat a child with subclinical hypothyroidism. وهو احنا بنبقى كده بالظبط لما نشوف حالة subclinical hypo نروح قدام ولا نرجع ورا. طب ايه الديسيجن الصح؟ خلينا نشوف. يا ريت حضراتكم تساعدوني في الكيس سيناريوز، انا متأكدة بتشوفوها في العيادة. This is an 8-year-old boy داخل يعمل tonsillectomy بالصدفة كده accidentally لقوا TSH عالي. The BMI and the height are normal, negative family history, asymptomatic, no goiter, TSH رقم دمه تقيل 7.8 عالي highish. T4 normal, antibodies negative, ultrasound normal. ايه رأي حضراتكم؟ Would you like to treat or wait? Thank you very much. Wait, مفيش أي risk factor في الموضوع. TSH less than 10, no risk factor. Let's wait. 6 months later قلنا نعمل follow up. نفس الموضوع بس الفرق الوحيد the TSH came up to 12.2. Can I ask you, would you like to treat or wait? Treat. Whenever the TSH is above 10, you have to treat, even if you don't have any risk factor. Now, this is another 10-year-old boy. The BMI is in the high normal and the height is in the low normal. His maternal aunt has got Graves' disease, autoimmune. Asymptomatic, he has goiter grade 2, as you see. TSH, another highish number. مش قادرة أقول very high, بس 8.9. The T4 is normal. The antibodies are positive. Ultrasound revealed goiter with heterogeneous echo texture. Who would like to treat this boy? Okay. Who will not treat this boy? Okay. خليني أقول لحضراتكم ده صح وده صح. بس أنا I would like to treat. ليه؟ لأن عنده risk factors. Positive family history of autoimmune disease, goiter, TSH high, antibodies positive, الالتراساوند فيه pathological changes في الثايرويد. ده مش ناوي يعديها على خير يبقى it's better to treat. لكن لو حد تاني قال والله أنا I will follow up وأشوف مش غلط. بس in such a case it's better to treat. This is a 7-year-old obese girl. BMI is very high. She's tall. Tall معناها she's not an endocrinal case. She's just simple obesity. Negative family history of thyroid disease, no goiter, T4 normal, TSH high, highish, antibodies negative, thyroid ultrasound normal. What would you like to do? وعايزة أقول لحضراتكم السيناريو ده بنشوفه كتير جدا. الأطفال الأوبيس وعندهم ال TSH عالي شوية. Who would like to treat? No. معظمكم قلتوا no. ماشي. Okay. Obesity alters the thyroid functions. We see various grades of obesity leading to subclinical hypothyroidism or even primary hypothyroidism. And long-standing subclinical hypothyroidism predisposes to metabolic syndrome. Obesity aggravates the situation. Subclinical hypothyroidism leading to metabolic syndrome, and the vicious circle goes on again and again. So what is the link between obesity and subclinical hypothyroidism? Obesity increases the fat mass and the serum leptin, which increases the TSH, leading to subclinical hypothyroidism. And obesity increases the fat mass, increasing the T4 disposal, which causes the T4 to go down, causing more and more rise in the TSH. Also, obesity increases the free fatty acid, being a chronic inflammatory state, leading to insulin resistance, metabolic syndrome, which exacerbates the subclinical hypothyroidism more and more. And this is a research conducted on lean and obese Danish children, showing higher prevalence of subclinical hypothyroidism in obese children. Again, looking at the components of metabolic syndrome, this study showed that abdominal obesity is a risk factor for subclinical hypothyroidism as well as hypertension. Now, let's go back to this girl. What did we do? We decided to follow up the girl. We do not treat TSH in obese children whose height is normal, except if the TSH is above 10. So we did not treat, we put the girl on a lifestyle modification. 6 months later, weight loss and lifestyle, the BMI went down. She's still very tall with no goiter, and the TSH went down to 4.6 on weight loss. The antibodies are still negative and the ultrasound is normal. So the TSH normalized here without starting treatment in such girl. What about this 13-and-a-half-year-old girl diagnosed with 45X Turner syndrome? She has short stature and delayed puberty. Look at the TSH, T4 normal, TSH high normal, 5.5. The antibodies were negative at this point, but the celiac screening was positive and she was found to have celiac disease confirmed by biopsy. And the bone age is delayed, FSH, LH, estradiol. As you see, both gonadotropins are high and estradiol is low. And she has a partial horseshoe kidney. She started growth hormone and sex steroid at this point. Now, we did a regular follow-up of the thyroid functions. The TSH jumped up to 8.5. This is subclinical hypothyroidism, and the antibodies became positive instead of being negative. And the bone age was delayed more 3 years than before. Who would like to treat this girl? Yes, thank you very much. We have to treat because the TSH is rising. She is a case of Turner syndrome, and this is a risk factor by itself. She has other autoimmunity, which is the celiac disease, and the antibodies became positive, and the bone age is more delayed. So yes, we have to treat. Now, going to the guidelines on subclinical hypothyroidism 2019, again, it was written as a statement, a very big statement. Treatment of subclinical hypothyroidism is controversial in children. And when to treat? If there is a high risk of progression to overt hypothyroidism. And in these two boxes, you can see the low risk and the high risk of progression. Idiopathic is low risk, whereas if you have a thyroid pathology, this is a high risk. If the TSH is less than 10, this is low risk. Above 10 is high. Antibodies, negative. This is low risk. Positive and rising is a high risk. Goiter is another risk. Syndromes like Turner, Noonan, Down syndrome is a risk. Other autoimmunities like celiac disease is a risk. Prepuberty and female sex is a risk factor. So looking at the baseline TSH, it's the most powerful predictor for progression to overt hypothyroidism. Again and again, please remember, if the TSH is above 10, you have to treat whatever the etiology, even if it is idiopathic. Because most of research agreed there's a risk of cardiovascular mortality, and some references say cancer if the TSH is above 10 and left without treatment. Idiopathic is self-limiting, and if you have a thyroid pathology, this is a risk factor, and again, there is no debate to treat if the TSH is above 10. What about the ATA, American Thyroid Association, on recommendations of treating children with subclinical hypo? The same question, to treat or not to treat? The same answer. In children, it is still controversial. In adults, it's very clear and easy. In children, it's really difficult. Again, better to treat. ما قالوش يعني 100% بس better to treat if the TSH is above 10, if there are symptoms, high risk of progression. Do not treat if the TSH is from 5 to 10 with negative antibodies, idiopathic, no goiter, asymptomatic, no thyroid pathology. بس مش هننسى البيشنت. We have to follow up every 3 months. لأن حتى لو ما فيش risk factor, it could progress later on. And the gray zone. والحقيقة معظم الحالات بتجيلنا في الجراي زون. أصعب حاجة. Consider treatment. يعني هنفكر نعالج if the TSH is 2 times the upper limit of normal, rising TSH, positive antibodies, goiter, short stature, metabolic syndrome, or thyroid pathology by ultrasound. So I think we have to balance the pros and the cons and the risk factor. It's not a straightforward condition in children. And we treat on individual basis. And this is the latest article, 2024, American Pediatric Journal, showing when to treat cases of subclinical hypo. لو حضراتكم بصيتوا, number 1, very clear. Any case with a TSH above 10, you have to treat. If the TSH is from 5 to 10, these are the risk factors that we consider in order to treat. So what are the pros or the benefits of treating patients? Improving the symptoms, improving the lipid profile, only if the TSH is above 10, preventing overt hypothyroidism. What are the disadvantages of overtreating? Improved symptoms will not occur if the TSH is from 5 to 10. Avoid overtreating patients. Remember, 40% revert to normal. 40% بيخفوا لوحديهم خالص. فاحنا don't rush to the treatment in children and the expense of lifelong medication. Again, we have to weigh the pros and the cons and treat on individual basis. And this is the algorithm of how we think about a case of subclinical hypothyroidism. Now, this is a 10-year-old girl with midline swelling of the neck, noticed at the age of 2 years, increasing in size, cystic, soft, and not tender. It moves with swallowing and protrusion of the tongue, no pain or lymphadenopathy. She's asymptomatic. TSH is 11.9, and the T4 is normal with negative antibodies. This is a very clear case of subclinical hypothyroidism. The ultrasound showed a cystic lesion, and the thyroid gland was not seen in its place. What is the next step? Yes, thank you very much. Whenever we cannot see the thyroid gland by ultrasound, we have to look for it by thyroid scan. Yes, there was ectopic thyroid in the hyoid in addition to thyroglossal cyst, and the CT scan confirmed this. Ectopic thyroid gland in a thyroglossal cyst and infrahyoid. الحالة دي غلبتني الحقيقة يعني. طيب نعمل إيه؟ How to treat such a case? الأول ندي علاج ولا ما نديش؟ TSH 11 ندي طبعا. لازم ندي thyroxine. بس لازم نعمل surgical removal of thyroglossal cyst because there is ectopic thyroid which could be carcinogenic and a source of infection as well. In infants, the situation is more critical. This is a baby diagnosed in neonatal screening with a TSH 14, ultrasound normal, asymptomatic. Who would like to treat this baby? Thank you very much. مش هنعالجه. ليه؟ لأن احنا مش بنعالج النيونيت إلا لما TSH يبقى above 20. double الchild. اوكي؟ ودي غلطة كله ناس كتيرة جدا بتعملها. And these are the guidelines regarding treating neonates with high TSH. Above 40, you have to treat بدون تفكير. Less than 40, venous sample. If the T4 is below normal or TSH above 20, you have to treat. Do a thyroid scan if you cannot see the thyroid gland by ultrasound. If the TSH is from 6 to 20, gray zone, الحتة اللي بتغلبنا, repeat after 2 weeks and follow up by thyroid ultrasound again. Now, البيبي ده جالي بقى بعد 2 weeks, TSH 22. Treat or not to treat? Thank you very much. We have to treat because the TSH is above 20. Again, if you are not sure, treat as early as possible. لأن طبعاً بنخاف على mentality will growth of children at this age. This is a 14-year-old girl with chronic kidney disease on dialysis. And she came asymptomatic with goiter grade 2, TSH الرقم اللي دمه تقيل 8.2. T3 and T4 normal, antibodies negative, ultrasound, large thyroid homogeneous, subclinical hypothyroidism with chronic kidney disease. حاجة very common بنشوفها في عيانين chronic kidney disease. مين يحب يعالج؟ اوكي، مين ما يحبش؟ الاتنين صح. اوكي، another controversial and debatable condition. طب معظم الريفرنسز بتقول ايه؟ Don't treat in chronic kidney disease except when the TSH is above 10. لأن خلقة ربنا this is a compensatory mechanism. As a part of metabolic disorder, and the TSH becomes high. If we attempt to overtreat those patients, بيحصل muscle catabolism, negative nitrogen balance, load على الهارت، وبالتالي no need to treat except if the TSH is above 10. عموماً هقول كلمة سهلة قوي في خلاصة المحاضرة، مفيش أي ريسك لو التي اس اتش أقل من 10 إن أنا ما أعالجش إلا نيو بورن بس. نيو بورن ده قصة لوحده. So if you decide to treat, start with low doses. Conclusions: subclinical hypothyroidism is less common in children than adults. Generally speaking, most of pediatric subclinical hypothyroidism resolves spontaneously. Decision of treating subclinical hypothyroidism in children is highly controversial. Children with a TSH above 10 must be treated whatever the etiology. Children with TSH from 5 to 10 are treated on individual basis. Children with idiopathic are self-limiting. Children with hypothyroidism pathology should be treated. Obesity-related subclinical hypothyroidism is not treated. You advise weight loss unless the TSH is above 10. Infants with a TSH from 6 to 20 need close follow-up. تاني بشكر زميلي وصديقي العزيز جدا على قلبي الأستاذ الدكتور أسامة حسين إنه اداني الفرصة إن أنا أكون في بورسعيد وسط حبايبي اللي بحبهم جدا. Thank you very much.